thank you, Dr. Ali Asghar, the Board of Management, all the VPs, and members of Pakistan Endocrine Society for your efforts for the Pakistan Endocrine Society. We now move to the first session. We have an exciting scientific program ahead, which will cover key topics in pituitary disorders, hypogonadism, hypercortisolism, and PCOS. It is my privilege to welcome our esteemed chairpersons. Our first chairperson is Professor Dr. Abdul Jabbar, who is a consultant endocrinologist at Medcare Hospital in Dubai. He is also a recipient of Lifetime Achievement Award by Pakistan Endocrine Society. Sir. Our second chairperson is Professor Dr. Najmul Islam, who is a professor of medicine and consultant endocrinologist at Aga Khan University, Karachi. He is past president PES and is recipient of Lifetime Achievement Award by PES as well. Thank you, sir. Our third chairperson is Professor Dr. Syed A. Mahar, who is a consultant endocrinologist at Aga Khan University and NICBD Karachi. He is Director Academics at Vice Academy and is Director of Pakistan Society of Obesity. He is also past President PES and past President ACE Pakistan chapter. Thank you, sir. Without further delay, I invite our first speaker, Dr. Urooj Lal Rehman, who is Associate Professor of Endocrinology at JPMC Karachi. She will be speaking on pituitary masses requiring surgery, pre- and post-operative endocrine assessment. So let's welcome Dr. Urooj.
Assalamu alaikum, everyone. Assalamu alaikum, Shaista. Thank you, Shaista, for the introduction. Thank you so much for the for the invite and giving me the opportunity. And congratulations to the organizing, to the president for this Midsummer, which every year we are doing. And I can see still the hall is almost full. So inshallah, as the day progresses, and we will see more attendance, hall is almost full. That's a great thing about today. So I'm going to talk about pituitary masses requiring surgery, pre- and post-operative endocrine assessment. So we're going to talk about, so we are deciding who needs surgery and how to assess the hypothalamic pituitary axis before and after the surgery. So the agenda is who needs surgery, then in which we'll talk about the indications. We will talk about pituitary guidelines, which the Pakistan Endocrine Society came up with in 2024. Then we are also going to talk about the size and mass effect criteria. Main will be pre-op endocrine workup and the post-op risk optimization and post-op endocrine assessment, which is very important. So a neurosurgeon should never proceed for a surgery of a pituitary adenoma unless an endocrinologist is on board. And it is endocrinologist who's going to say, yes, you can do this surgery, or no, you cannot do this surgery. It's not the neurosurgeon. The captain over here is the endocrinologist. This we need to teach all and neurosurgeons, physicians all over Pakistan, if we want these tumors to be treated properly. So why operative care matters? So pituitary adenoma accounts for roughly 10 to 15% of the intracranial tumors, and outcomes after transcranial surgery depends as much as meticulous perioperative endocrine and fluid management which is done during the surgery. So it's not only the surgical procedure in the surgical hand, it's the endocrine element, how this element has been managed. So tumors have been categorized as functioning adenomas, the prolactinomas, the acromegaly growth hormone secreting tumors, the ACTH tumors, and the TSH secreting TSHomas, and then non-functioning, which present basically with the mass effect. And the mass effects can be optic chiasm compression or cavernous sinus invasion or apoplexy. It is a multidisciplinary team. This should be involved in these patients. So we need an endocrinologist, a neurosurgeon, an ophthalmologist, an anesthesiologist, and critical care. All of us need to work together for the better results. So which masses needs, the pituitary masses need surgery? Of course, all those which are secretory, they need surgery. So acromegaly, Cushing's, they need surgery. Then, but of the secretory, there's one which is prolactinoma. And this one is a tumor which can beautifully be treated with one drug. And now that drug is available, as mentioned by Dr. Ali Asghar. So this is the one which can be treated with the drug, and that drug just dissolves away the tumor. So that one, we need to talk about that as well and tell the neurosurgeons that we are not going to go for surgery in these patients. We're going for the secretory except for the prolactinoma. And if there is mass effect, so chiasmal compression, or if it is causing cradle neuropathies going down into the cavernous sinus, and prolactinoma, when would you treat, when would you go for surgery in prolactinoma? That's important. If the patient is having resistance to the treatment or patient cannot take the medicines, then in that case, you need to go for surgery. So surgery versus medical conservative management. So prolactinoma, it is dopamine agonist, the cabergoline. Very good drug, again, reduces the levels in 24 hours, dissolves away most of the tumor within 6 months. So this is the point where we do not want a surgery. Then growth hormone, so in acromegaly we will go for surgery, Cushing's will go for surgery, and TSHoma, again, very rare. It is said an endocrinologist seeing one case in the lifetime. Unfortunately, I have seen 3. So what we have observed is that first it was anti-thyroid drugs, which you are used to control the symptoms. But now we have seen, now the guideline says that it's the cabergoline, which can help over here as well. Sorry, octreotide, which can help over here as well. And the octreotide has shown reduction in size of the tumor as well. So guidelines still say the first line is surgery, but there are case reports that might be in future, we will be giving octreotide as first line for this as well. And of course, for non-functioning, if small, we will observe and look for the visual field defects, etc. Otherwise, we will go for surgery. These are our guidelines, which we came up with, the PES came up with PESNO in 2024. And these were, the recommendations were that multidisciplinary decision-making should be there. Observation has a definite role and has a defined role. It's for the asymptomatic microadenomas. Apoplexy should drive towards the surgery and urgency. There should be a standardized workup which should be done in all. Then adjuvant radiotherapy was given importance in our guidelines, because medical therapy, if we look at the acromegaly, if we look at the Cushing's, medical therapy is not readily available, or if it is available, it is very expensive. But stereotactic radiosurgery is available. Fortunately, in Karachi, we have 2 centers which have stereotactic radiosurgery, and they're doing it for free. We have a center in Lahore, and I think one center in Islamabad is also in process, I guess. So this is more easier for us. So in our guidelines, as usually we are sending these patients for radiosurgery, we have mentioned that that can be the second line instead of the medical therapy. And we keep medical therapy for the reserved for recurrent or residual adenomas, or bridging therapy. As a bridging therapy, you gave radiosurgery, and then there's time period when it will be effective. During that time, we give it as a bridging therapy. Ophthalmological surveillance needs to be done. Imaging surveillance need to be done. This point, I added care delivery, teleconsultation. This is times of phone, mobiles, WhatsApp. We keep on talking to our patients. We can keep on going back and forth with them. And this can be used because these patients, some of our patients coming from Iran and Afghanistan, so you can consult with them and talk to them rather than making them come. So these should be part of the care delivery. So baseline endocrine workup, any pituitary adenoma which is not acromegaly or Cushing's, or you need to do a baseline endocrine workup in all them. Cortisol excess is very important. Unless you think it's a Cushing disease, and the workup will be very different, then you'll have to do an evening cortisol or overnight dexamethasone suppression test. But if the patient doesn't seem to be Cushing's and has a pituitary adenoma or is coming with the symptoms of the adenoma and you want to do, then you have to do the cortisol excess. You have to look at the cortisol levels, and that is 8 a.m. cortisol. And ACTH stimulation test if it's a gray area. Okay? And then you also have to look at the thyroid excess. You have to rule out the central hypothyroidism. It's usually missed. Prolactin to see if it is prolactinoma or it is the mass effect. Prolactin can be raised in large tumors because of the mass effect, but it will not be that high as the tumor is. So you have to do that. Then growth hormone and IGF-1. Growth hormone or not growth hormone, IGF-1 is recommended, and IGF-1 should be done in all the pituitary adenomas. Gonadal excess needs to be seen, and electrolyte and osmolality, very important, especially soon after the surgery. So you need a baseline for that. What testing sequence? Cortisol, ये important है, इसलिए I have mentioned. We need to test cortisol and replace it before we start replacing the thyroid, even if there is thyroid deficiency. So we need to test and replace cortisol before we start treating the thyroid. This is very important. Otherwise, patient can go into crisis. So tumor-specific or preoperative concentrations, if patient has acromegaly, so you'll need to look for the airway, the cardiomyopathy, the sleep apnea, the glucose intolerance. If the patient has Cushing's and hypertension, hyperglycemia, thromboembolic infection risk, prolactinoma, then you need to confirm whether it is true prolactinoma. And if it is apoplexy, then you have to look for urgent cortisol assessment and giving the hydrocortisone. Imaging needs to be done, dedicated pituitary MRI with contrast to define the size, the extension, the cavernous sinus invasion, visual field perimetry, very important. Baseline पे surgery से before the surgery you need to do this. Visual acuity and endoscopy needs to be done. CT for bony anatomy. This is for the surgeons, they would be doing it. Immediate post-operative monitoring. So this is more for the neurosurgeons, but the point which is important for us is the fluid balance, serum sodium, and then steroid coverage. So as endocrinologists, we are more interested about the serum sodium levels and about the steroid coverage, whether it is going on or not. So we maintain perioperative hydrocortisone dosing until the adrenal excess is reassessed. This is the triphasic water balance response we need to remember. So there can be diabetes in days 0 to 2. There will be diabetes insipidus, which is a transient diabetes insipidus, which is because of the axonal shock. The patient can have polyuria and dilute urine and rising sodium. Friend, from 3 to 7, SIADH will set in because the ADH will be released from the degenerating neurons, and there is risk of delayed SIADH as well. So we have to keep that in mind as well. Permanent DI, uncommon, and reflects significant posterior pituitary stalk injury, may need long-term therapy with desmopressin. So day 1, continuous stress dose hydrocortisone. Do not test cortisol while on treatment dosing. So never do a cortisol test if a patient is already on steroids. Day 1 to 3, you check for serum sodium and monitor for early diabetes insipidus. Day 3 to 7, you check the sodium trends for delayed SIADH. Week 1 to 2, you monitor cortisol of the hydrocortisone to assess the axis and if patient is clinically stable. We need to remember this. 6 weeks, full panel cortisol, free T4, TSH, gonadal axis, repeat prolactin if relevant. And then at 3 months, we do a IGF-1 reassessment and confirm any replacement doses to be given. Here, remember, when there is central hypothyroidism and we are treating it thyroxine, TSH is not that important. It's the FT4 which is important. We'll look at FT4. We might not do TSH over here as well. So from 6 to 12 months, so this is till 3 months, then from 6 to 12 months, you repeat MRI, ophthalmology review, and bone health assessment, and then annually long-term hormonal surveillance, recurrence monitoring, and quality of life review. Confirm the need of the replacement. So these patients can have panhypopit soon after the surgery or as the time goes by. So you have to keep on checking for all the hormones. Cortisol, for cortisol, you taper hydrocortisone when stable, reassess with 9 AM cortisol off steroid, refer for ACTH stimulation test if equivocal. Thyroid, recheck free T4, TSH. TSH, even if it's normal, it is the free T4 which is important. After replacing with thyroxine, you will not do the TSH, you will follow with T4. And this is done at 6 weeks. Gonadal, reassess at 6 to 12 weeks, replacement guided by symptoms plus biochemistry, not by biochemistry only. So you have to ask the patient about the symptoms and then you have to treat. Growth hormone, defer formal testing to 3 months, treat confirmed adult growth hormone deficiency if symptomatic. Posterior pituitary, continue desmopressin only if DI persists. The acute triphasic window. Trial of periodically. And then you stop it and then you see and then you give it and till the patient you need to find out whether the patient is coming out of it or not, or it is a permanent DI. So clinical surveillance first, after the surgery, MRI at 3 months, then per tumor type and resection status. Annual visual field testing should be done, biochemical recurrence marker per tumor type. Replacement therapy review should be done every time. Reassess every replaced axis at each visit. Doses change with age, weight, and intercurrent illnesses. Provide a steroid emergency card, very important. They need a card or a bracelet so they know if something happens, people know that they need high doses of steroid. And sick day rule needs to be taught to them. Coordinate transition of care with primary care and obstetric team. Very important. So female patients, unki obstetric team ke saath, whenever they are pregnant, you have to be in touch with them. So take home points, surgery is driven by size, mass effect, apoplexy, medical therapy failure, and functioning status. Test the cortisol axis before thyroid replacement, both before and after surgery. Avoid testing cortisol while the patient is on stress dose hydrocortisone. Anticipate the triphasic water balance response, not most missed at SIADH phase post-discharge. Build replacement decision on serial biochemistry plus symptoms, not a single post-op value. Thank you.
Thank you, Dr. Urooj, for such a wonderful talk. Regarding questions and answers, we have 2 standees placed in the hall, and the QR codes are there on it. You can scan the QR code, type your question along with the speaker name, and we will take those questions at the end of the session. Okay, our next speaker is Dr. Naeem Durrani, who is Associate Professor and HOD at ARIA, Institute of Health and Medical Sciences, Quetta. He is also General Secretary of Pakistan Endocrine Society, and he will discuss to treat or not to treat cases of functional hypogonadism, a reversible epidemic. So let's welcome Dr. Naeem.
Assalamu alaikum, everyone. Thank you. I will thanks all the Dr. Urooj has said to spare some time and speaking in front of, because all the chairs are my teachers. So Dr. Najmul Islam was my supervisor. It will be difficult, but I will try. So the functional hypogonadotropic hypogonadism, treat or not to treat, a reversible epidemic. I will not call it a reversible epidemic. When we will see in our slides, it is not an epidemic, but is even endemic, which we are missing in many cases. The ARIA Institute, where I'm associate professor, it is grown very in a short time, and now it has been recognized as an endocrine center where I'm the supervisor. So I have no conflict of interest. Whenever we are thinking about the functional hypogonadotropic hypogonadism, the anorexia nervosa, this comes in our mind. And we say that the functional hypogonadotropic hypogonadism occurs in these patients, and of course the athlete's triad, in which they do exercises for the excessive levels, and which leads to the menstrual abnormalities and bone loss and osteoporosis. But here comes the real culprit, which we are missing. The diabetes, obesity, and the diabetes is very common for the functional hypogonadotropic hypogonadism is very common in these, and it is often missed, and it is often very under tested in these patients, the functional hypogonadotropic hypogonadism. These are the cases, real cases. This was a 30-year-old male married for 1 year with with no libido and almost impotence. With a past history, he had a weight of 110 kg, which he lost 60 kg, bring it to 50 in 1 year. I think it was in the fear of the marriage. And as secondary sexual characteristics are normal SPL, testes 15 ml, slightly softer. 9M testosterone and FAI was low to undetectable in the 2 morning samples. The FSH, LH, testosterone, prolactin, and the MRI was normal. How you will treat, we will see later in this. Will you counsel or give him a cognitive behavioral therapy? Start him on testosterone or testosterone and combination cognition behavioral therapy. This is another case, 45 years old, married, having 2 kids. The last kid is almost 5 years back, and he's planning for another one. And his weight is 120 kg, BMI of 42, fasting blood glucose is 190, HbA1c 12, lipids controlled with TG level of 450, HDL low, TSH prolactin normal, FAI low, with normal FSH, LH, MRI normal, and the Cushing was ruled out by 24-hour urine cortisol. How to manage this patient? Start diabetes control, weight loss, and start testosterone. Diabetes control, weight loss, start him on a beta HCG, that is IVFC. Diabetes control, weight loss, and start him on a clomiphene. So this is the picture showing the normal hypothalamic pituitary axis, which acts normally in the center. And these are the interrupters at the different level, like the insulin, glucose, act on the hypothalamus. The low leptin and the leptin resistance, they also act on the hypothalamus to interrupt with the GnRH release. On the another ends are the glucocorticoids, the medicines which are very important, causing the glucocorticoids or opioids acts on the hypothalamus. There are some acting on the pituitary, like the inflammatory cytokines, the medications used for the HIV and the opportunistic infections, the elevated estradiol from the adipose tissues, and there are some reactive oxygen species which can act on the gonad as well. So starting with the very common, that is the obesity, which is caused by the triad of the obesity, in which the aromatase activity convert the testosterone into estrogen, which act on the negative feedback effect on the pituitary to decrease the LH level, and the leptin levels leptin resistance in the very high leptin in the obesity, which leads to leptin resistance by the down regulation of the leptin receptors, and ultimately the kisspeptin, which is the marker for releasing the GnRH. And last but not the least, as the obesity is chronic conditions, like the there are inflammatory cytokines are raised in the obesity, like the interleukin 1 and the TNF factor alpha, which act on the pituitary, as well as they can damage the Leydig cells of the testes. So in the type 2 diabetes, if you can see the prevalence, it is from 33 to 57%. 13% are diagnosed by the total testosterone, and 17% diagnosed by the free androgen index. But the symptomatic profile, the erectile dysfunction can occur in 72% of the patients, and 60% reported reduced libido. These all occur due to overweight. The BMI is increased, which is leading to the low testosterone level. HbA1c raised, leading to low free testosterone level, and the triglycerides leading to the low testosterone level, and other, like we mentioned, in the diabetic patients, and they are often obese. The multiple factors can cause the factors which can lead to the low testosterone level in these patients. The female hypogonadotropic hypothalamic amenorrhea, there is imbalance between the energy intake and nutrition. They take low energy intake, and their nutrition is poor. On the other end, they have the other is the energy expenditure, like stress. These all contribute to low energy availability disorders eating, which leads to the menstrual irregularities, infertility, and ultimately the bone loss. And in these patients, there is only in this functional hypogonadotropic hypogonadism can have a mortality due to cardiovascular diseases, due to the functional hypogonadotropic hypogonadism, the low estrogen levels, or the other electrolyte imbalance. This is another emerging cause of functional hypogonadotropic hypogonadism, the HIV, which is becoming more common in our country as well. Thousands of cases has been reported in the AKUH and Balochistan as well. The prevalence of hypogonadism is 13 to 40%. These occur in the low age group, 20 to 60%. 80 to 100% cases are secondary, and 50% are present with the compensated subclinical hypogonadism, that is with the normal testosterone level and high LH level. The symptoms are similar to the other hypogonadism, but there are some diagnostic fog which can occur in general population, which any patient who presenting with the low libido and their hormonal workups are normal. The effects can be due to the medications used for the HIV treatment. Their side effects, HIV-related fat redistribution, and the stigmata, because these patients, when they know they are HIV, it is a psychological stigma for that, and every psychological illness can lead to the functional hypogonadism as well, any type of hypogonadism. So if we summarize how to the phenotypes, like we discussed in the severe obesity, there is leptin resistance and aromatase activity we discussed. The key biomarkers are low sex hormone binding globulins with high estradiol due to the aromatase activity. The primary intervention, when we are going for, not for treating that, to use the GLP-1 and the bariatric surgery. In type 2 diabetes, there is insulin resistance, which can be calculated by the OMA-IR model. High HbA1c, low free testosterone, and the intervention should be glycemic insulin control. In the functional hypothalamic amenorrhea, where the low energy is availability, the key biomarkers are low LH, FSH, low estradiol. In these, the intervention should be caloric restoration and the cognitional behavioral therapy. In the patients living with HIV, the viral load and the medications are the culprits. Treatment biomarkers that there are low normal testosterone with high LH, which is as we discussed the subclinical. Comorbidity management in these patients, which is causing the infections which are rare, they can be managed with testosterone therapy as well when needed. So this is the diagnostic pathway, how to go to diagnose the functional hypothalamic hypokalemia. These patients are symptomatic. There are the sexual symptoms, fatigue, bone loss, and first they should be checked for the free testosterone level, fasting levels at least 2 times in males, and in the females the estradiol level, and then to confirm whether it is primary or secondary, the FSH and LH should be checked, and then rule out the other causes of hypogonadism like prolactin, the TSH, and review medications which are causing them, and MRI to rule out the organic causes of the gonadotropic hypogonadism. Diagnosis require both symptoms and biochemical confirmation due to heavy overlap with the other chronic conditions. So the treatment which we are considering in not to treat in obese patient, our target should be to wait for the weight loss of at least 20% or more, which can be achieved with low caloric diets, improve insulin resistance, the emerging GLP analog like liraglutide, semaglutide, and others. The sexual function and the quality of the sperms are improved, and bariatric surgery can be reserved when the other options are not available. For familial hypothalamic amenorrhea, there should be increased intake and decrease exercise. Not cessation of the exercise is recommended, and the BMI target should be to achieve of 18.5 in our part of the world. There should be a multidisciplinary care is mandatory, nutritional, mental health, and psychological support with cognitive behavioral therapy. Mental health support and counseling is very important in these patients. In HIV, optimize the medications, manage overlapping frailty, co-infections, smoking, and alcohol cessation, not only in them, but in all cases. Alcohol should be avoided, and if they're insisting, should be taken in the moderate amount. So when our first, like the intervention fails, the lifestyle modification, when we cannot achieve, then we can consider the medications. Like for the obesity and HIV, we can use the testosterone therapy, and for functional hypothalamic amenorrhea, menses resumption, short-term estradiol with cyclic progesterone only if lifestyle fails. And in any patients in functional hypothalamic gonadotropic hypogonadism, if they are planning for the fertility, the pulsatile GnRH pump is the first line therapy. And the second one is the cyclic use of the gonadotropin, and clomiphene citrate can be used in the females and males, and in the females if the estradiol levels are adequate. For the functional hypothalamic amenorrhea, do not use oral contraceptives pills solely for the restoration of the menses or BMD improvement. Avoid bisphosphonate, denosumab, testosterone, and leptin due to limited evidence in functional hypothalamic amenorrhea, but the recombinant PTH can be used in these patients. Why we treat these patients? Because there is, if you we do not treat these patients, there is consequences of decreased muscle mass strength. Tall stature can occur if the condition occurs before the prepubertal age, and there are increased risk of autoimmune diseases like the hypothyroidism, which can be associated with it. But some autoimmune condition like celiac diseases, multiple sclerosis can also cause functional hypogonadotropic hypogonadism. If untreated, functional hypogonadotropic hypogonadism leads to significant skeletal, reproductive, and functional morbidity, despite patient having a near normal life expectancy. In a functional hypogonadotropic hypothalamic hypogonadism, if these patients are desiring for the fertility, because if the mother is not healthy, the nature has developed this suppressing of the hypothalamic pituitary gonadal axis for the very ill mother to conceive. Because if in this condition of health she delivered, there will be complications. So clinical impression, it is reversible. FHS, familial lipo is in an environmental, behavioral, adaptive, not permanent failure. Treat the root cause first. Insulin is a primary driver. Actively screen and address insulin resistance in routine diabetic care to protect androgen status. Be aware of the diagnostic fog, which occurs in the normal patients who have a normal testosterone FSH level. Multidisciplinary team is compulsory, especially in the functional hypothalamic amenorrhea. This is the case 1. I have given the answer here. I started this patient on testosterone and cognitive behavioral therapy at the same time because her wife was on the urge to break the marriage. So I started the testosterone and referred him to the psychologist. Then thereafter I stopped the testosterone, and he has now fathered two children. In the another patients, I started, because if I started the testosterone, it will lead to, because the patient was desiring the fertility. If I started testosterone, it will lead to the decreased spermiogenesis. And he was very poor, so I started him on a clomiphene, and on which he fathered another child as well. Don't be confused with this file. This is the summarization of my whole presentation, how to deal with the different case scenarios. Thank you very much.
Thank you, Dr. Naeem, for such an insightful talk. Our next speaker is Dr. Uneeba Syed. She is Assistant Professor of Endocrinology at Allama Iqbal Medical College, Lahore. She is also Vice President, Pakistan Endocrine Society, Punjab chapter. She will be talking on hypercortisolism, practical guidance from available clinical evidence. Let's welcome Dr. Uneeba.
If we can have Bismillahirrahmanirrahim. Assalamu alaikum. Thank you so much for the kind introduction, and thank you so much the organizing and scientific committee for giving me the opportunity. Hypercortisolism, very important, very common, and in the next 15 minutes, I'll just try to wrap up the details of it. So when we say hypercortisolism, what we mean is that if it is from any cause, it will be known as Cushing syndrome. However, if it is due to an ACTH-producing adenoma, it will be Cushing disease. And then we have mild autonomous cortisol secretion, which is basically mild ACTH-independent autonomous cortisol secretion from an adrenal adenoma without clinical features of a full-blown Cushing's. Coming to the etiology, this is a very nice Lancet diagram, which I really liked. So what we see here in the green circle is about 70 to 80% of the causes are ACTH-dependent Cushing, which is when then seen 80 to 90% amongst them have corticotroph pituitary adenoma, which mostly occurs between the age of 30 to 40 years. Now, 20% of these will be via ectopic ACTH secreting tumors. Now coming to this orange part, that is ACTH independent Cushing's, it will have 70 to 80% unilateral adrenal adenomas, 20 to 30% of adrenal cortical cancers, and the rest are the rare causes, which can be bilateral adenomas, McCune-Albright syndrome, and so on. These are basically the adenomas or neoplastic. And then we have non-neoplastic Cushing, which is actually a condition where a patient displays the physical and biochemical signs of Cushing, but the excess cortisol here is secreted by the overactivation of the body's stress system, that is the HPA axis, rather than a tumor itself. And there are multiple causes, including the alcohol, the CKD, and the neuropsychiatric disorders. Now, should we screen everybody? We have a particular guidelines on whom to screen. So we screen patients with adrenal masses, which may be asymptomatic or symptomatic. So when we look at these patients, 20 to 50% of these will have mild autonomous cortisol secretion. Less than 5% will have adrenal Cushing's, and there is a higher likelihood of hypercortisolism if the tumor is more than 2.5 centimeter or they are bilateral adrenal nodules. Then pituitary adenomas, we screen as Dr. Urooj has very nicely explained. Then patients with the clinical features of Cushing's, and I think all of us have seen these pictures from Davidson. Then we have unexplained comorbidities potentially due to hypercortisolism, and this was this article which showed hidden hypercortisolism in whom bone fragility, I've just highlighted it, hypertension and diabetes were the presenting manifestation of an otherwise silent hypercortisolism in almost 34.7, 32.7 and 6.1% respectively. Very important study, the Catalyst study, in which the prevalence of hypercortisolism in patients with difficult to control type 2 diabetes was seen in almost 24%, not essentially, not necessarily the Cushing syndrome, but hypercortisolism was there. So you also screen these patients. Now, how you approach hypercortisolism? There are three main steps. You document the hypercortisolism, you identify the subtype, and then you do the localization study. When you need to document the hypercortisolism, the first step is you need to understand, does the patient take exogenous glucocorticoids? You have to talk to the patient, you have to ask the patient. Then you assess the clinical likelihood of the endogenous Cushing syndrome. So most of the authors, they encourage the application of the Bayesian approach. What exactly Bayesian approach is that this is basically the post-test probability. But then there are a few authors like Nugent or Neon, they came up with pre-test probability, and the most recent one is this Cushing score, which actually categorizes the clinical pre-test probability using a 17.5 point scale. It is based upon specific symptoms and the risk factors, with low risk class having less than 1% of the disease probability and the high risk class of more than 70% of the disease population. When you have done this, you look for an abnormal circadian rhythm with late night salivary cortisol, impaired glucocorticoid feedback with overnight 1 mg DST, or you look for an increased bioavailable cortisol with 24 hours urinary free cortisol, and at least 2 to 3 screening tests are required for this. And these three tests, the purpose of these few slides is I just want to mention that there are false positives and the false negatives with all of these tests. And just look at this, the estrogen, the pioglitazone, very commonly given, but you see that false positive can occur with this, with 1 mg dexamethasone suppression test. Similarly, for 24 hours UFC, although with sensitivity of 91 and specificity of 81.5, you need to be aware of the false positive and false negative. For the late night salivary cortisol, people who are shift workers, who work at night, who are critically ill, who have depression, this test cannot be done for those patients. Okay, so when we have screened the patient, what we need to understand is that the pseudo Cushing's or the non-neoplastic Cushing, it needs to be ruled out. So abnormal test results, they tend to be mildly elevated in these patients, and if you do urinary free cortisol, it is always within the threefold of the normal level. Now the DEXA-CRH test and this DDAVP, this is the desmopressin test. This is very important, and they actually differentiate pseudo-Cushing with CD very effectively. When you move forward, then you need to understand either it is an ACTH independent or ACTH dependent Cushing, for which very conveniently you can measure ACTH. Now, which would tell you if you have to move towards the adrenal CT or pituitary MRI. Now, with pituitary, if you have an adenoma present, which is more than 10 millimeter, you presume it is a Cushing's disease. However, if the adenoma is between 6 to 9 millimeter or it is not seen, you either go for petrosal sinus sample, bilateral, or CRH and desmopressin test plus whole body CT, and use C2 stars with it. This is because this alternative option does not have clear consensus, but it is written, so I had to mention. I'll talk about BIPS, which is bilateral inferior petrosal sinus sampling, and what you need to see is that the IPS to the peripheral ACTH ratio is, if it is more than 2 before CRH and more than 3 after CRH, it suggests CD. And then you have intersinus ratio of 1.4. If it is more than 1.4 in the basal condition, it shows lateralization. When the treatment goals, why we have to treat, either normalize cortisol level or actions at its receptors to eliminate the sign and symptoms, and treat the associated comorbidities. And this is very, very important. You cannot just treat the disease and leave the comorbidities behind. And treatment, the first line treatment remains the surgery, whether it is pituitary or it is adrenal. And we see that with pituitary surgery, 83% of microadenoma, 68 macro, and 80% overall remission can be seen. If surgery fails or it is not controlled, no surgery is there, or the recurrence is there, and you have to look for medical treatment. And in 2021 guidelines and the new consensus, medical treatment has been given a lot of value. And then we always, obviously, bilateral adrenalectomy remains the last option. Now, medical therapies that I was talking about can either be pituitary directed. The dark green color shading would tell you the current pituitary directed are biserotyde, cabergoline, or temozolomide. Then the retinoic acid, and the other two are the novel ones. Similarly, metyrapone, mitotane, adrenal directed. And then we have the other new drugs, which I'll be mentioning in my further slides. Similarly, we have GR antagonists, mifepristone, and relacorilant. Look at the table. This is a busy table, but this is very important. You actually know the steroidogenesis inhibitors, and if you need to look at one, just look at osilodrostat, the last one, because this one is discussed quite frequently in the newer guidelines. It inhibits cytochrome P11 beta 2, and it is also given in the severe hypercortisolism. Now, which medical therapy we need to select? There are specific points that might help you. If there is a need for rapid normalization of cortisol, you go for an adrenal steroidogenesis inhibitor. Osilodrostat, as I said, and metyrapone have the fastest action. But if your patient is in ICU, etomidate can be given because it is given IV via central line. In the mild disease, and especially if there is a potential for tumor shrinkage, you go for biserotyde or cabergoline. If there's any history of a bipolar or impulse control disorders, you avoid cabergoline. If an expert pituitary endocrinologist is not available to monitor the treatment response, use mifepristone very cautiously. And in pregnant women or those females who desire pregnancy, consider cabergoline or metyrapone, although no CD medications are approved for the use of pregnancy, as we all know. So moving forward from here, I just have a few points regarding cyclical Cushing's, which is actually a successive periods of spontaneous cortisol secretion alternating with periods of normal or periods of normal or hyposecretion. Now, these patients actually, they have the cause, similar causes. 54% have Cushing's disease, 26% have ectopic, and then 11% have adrenal disease. More common in females between the age of 50 and 60, you mostly see this. Now, what happens in these is, according to a majority of the authors, the patients with cyclical Cushing's exhibit at least 3 peaks and 2 trough of the cortisol for us to diagnose them as a cyclical Cushing. However, there are also authors who say that 2 peaks and 1 trough is sufficient to diagnose. So it can be either of them, but larger data says it is 3 peaks. Now, interesting thing is the onset can be ranged from 12 hours to 510 days. So this is a big period with an average period of about 21 days. The clinical features, the diagnosis, and the treatment is more or less same. But the only thing I need to mention is the hair cortisol concentration, because that was interesting for me as well. Now, what we see here was that 1 centimeter of the hair segment reflects the cortisol level within a period of 1 month. So, which means that the length of the hair, it is possible to detect the cortisol level in the previous months or the years, and the sensitivity and specificity of hair cortisol is quite good as well, reaching up to 98% of the specificity. Now, Spanish guidelines in 2025, they have mentioned severe hypercortisolism, and severe hypercortisolism in its extremely serious clinical condition that causes life-threatening risks to the patient due to intensity of hypercortisolism, which means that urinary free cortisol levels for the diagnosis are 5 times the upper limit of the normal. It is also characterized by severe complications like hypokalemia, uncontrolled hypertension, sepsis, heart failure. And then the biochemical definition includes serum cortisol more than 41 grams per deciliter and or severe hypokalemia. This is severe. And then we have life-threatening hypercortisolism, in which the urinary free cortisol exceeds more than 10 times the upper normal limit. Now this, what changes it, that you have to treat before you start investigating. So therapy of severe hypercortisolism is the rapid acting inhibitors. And then we have to decide whether you go for block and replace or titration. I'll just have a few words over this in the next slide. And then cortisol replacement, especially if you're going with block and replace. Also, you have to look for thromboembolism, hypokalemia, infection, and the psychosis. Because 10% higher risk of thromboembolic phenomena is present with severe hypercortisolism. Low molecular weight heparins can be given. Now, metabolic vulnerability, which is hypokalemia, this is probably the 3rd time I'm saying hypokalemia with severe hypercortisolism because it is that important. And hyperglycemia management should be there. Psychiatric alteration, expert involvement is required. And then these patients also need vaccinations. What you do is you give osilodrostat, which is an oral drug, cytochrome 11 beta 1 and aldosterone synthase inhibitors. They're highly potent and they have normalized urinary free cortisol in 82% of the cases. Why ACS is written? Because the severe hypercortisolism was caused by an ectopic source. Then etomidate is the ICU rescue. It was IV continuous infusion, same mechanism of action. However, it is needed for critically ill, septic or psychotic patients who were unable to take oral medication. And then we can have dual therapy, which is ketoconazole and metyrapone, and triple therapy, which is the extreme rescue, which would add ketoconazole, metyrapone, and mitotane. With both of these, you have to understand that you might need to replace the steroid after giving them. So which to choose, block and replace or titration? as the names tell you, for block and replace, the high initial doses to completely suppress the endogenous cortisol, and then you supplement with exogenous hydrocortisone. There is rapid control of severe cortisolism, hypercortisolism, and rapid return to circadian rhythm. There is lower risk of adrenal crisis, obviously, because you're giving steroids, and harder to evaluate the underlying secretory state later. This is the drawback. When we look at the titration, it is preferred for the less severe cases. So this just tells you everything. You have to prefer the block and replace. But then for the titration, the low initial doses, you step up, obviously, as the name, it takes significantly longer time, and there is a higher risk of adrenal crisis. And finally, bilateral adrenalectomy to hai hai. If there is life-threatening hypercortisolism which fails the medical therapy, or metastatic ectopic CS where primary surgery is ineffective, it provides immediate and permanent resolution. However, there is permanent adrenal insufficiency, there is increased perioperative thromboembolic risk, and the risk of Nelson syndrome is about 20 to 53% when you're dealing with the severe hypercortisolism. When you talk about prognosis, we have a 5 years mortality of 30 to 50% if left untreated. The treated Cushing syndrome has good prognosis, but mortality is still increased, and obviously all of us know cardiovascular stands at the top. Metabolic syndrome and cardiovascular risks, although it does improve, but it does not touches the baseline. Mood and cognitive disturbance, it may persist for a longer period of time and require the professional help. And that will be all from my side. Thank you so much.
Thank you, Dr. Uneeba. Our final speaker of this session is Dr. Aisha Sheikh. She is a consultant endocrinologist at Aga Khan University, Karachi. She is also immediate past president PES, and she will be talking on PMOS and evidence-based comprehensive management in 2026. So let's welcome Dr. Aisha.
Bismillahirrahmanirrahim. Assalatu wassalamu ala khatamin nabiyyin. Assalamu alaikum, and I'm really grateful to Organizing and Scientific Committee for inviting me for this talk, and thank you very much for your kind introduction. And it's an honor to present in front of two of my teachers as well. So most of you are aware that there's a nomenclature change recently. PCOS is now POMS, and why is it done that? Because PCOS anchored to ovarian morphology implies that pathological cysts are there, but this was inaccurate. These were actually arrested follicles that were visualized as cysts. And PCOS nomenclature actually narrowed the clinical attention to gynecology, contributed to diagnostic delays with up to 70% of individuals with delays or misdiagnosis. The current nomenclature actually focuses on a polyendocrine metabolic ovarian syndrome, and it aligns the terminology with the biological architecture of a multi-system disorder that is affecting a significant population in globally. And it is actually paralleling. You must be aware that recently NAFLD is now categorized as MESLD, and this transition is centered to systematic metabolic risk and reducing stigma of fatty in that terminology. So why the old name of PCOS failed? 1 in 8 women are affected by PCOS worldwide. That accounts to almost more than 170 million globally. 70% remain undiagnosed. There are delays or misdiagnosis, and 30 to 35% has impaired glucose tolerance. And interestingly, this is independent of their body mass index. There's a 2.7-fold higher risk of endometrial cancer as well, and a lifetime risk up to 9% of endometrial cancer. So that was important that nomenclature change was long awaited, and recently the 56 organization consortium has penned down this name of PMOS. Let's go through an interactive case, and I'll request the house attention over here and participation as well. So this is a 23-year-old lady, single. She's referred by dermatologist. She has hypothyroidism, which is well controlled, acne, hirsutism, oligomenorrhea, that is 6 cycles per year for 5 to 6 years. Menarche was 14 years of age, and the cycles were irregular since then. Her BMI is 21. Her Ferriman-Galvez score is 8 to 9, which is mainly facial, and there is acne. Her labs report reveal normal TSH prolactin at 17 OHP level. You can see FSH 4.4, LHS 9.3. Ultrasound shows a polycystic ovarian morphology. Testosterone is normal. Family history is positive for type 2 diabetes, hypertension, ischemic heart disease, and obesity. So can I have a show of hand? Is this PMOS? A, PMOS is not confirmed. Additional screening is required. So how many for A? How many for B? This is not PMOS. Testosterone is normal and cannot diagnose without biochemical hyperandrogenism. So can we have a show of hands? How many for C? PMOS confirmed. Okay, clinical hyperandrogenism is there with Ferryman-Galvez score is 8 to 9. Ovulatory dysfunction is there, and PCO morphology satisfy the Rotterdam criteria. And D, how many still think that they will repeat an ultrasound in 6 months and reassess? So this is wonderful. You are correct. Most of you have opted for option C. How do we define menstrual irregularity when it comes to these women presenting in your clinics? Remember that 1 year post-menarche, this is a normal pubertal transition time when hypothalamic pituitary ovarian axis is maturing, and this is a normal phenomena that their cycles would be irregular. Do not evaluate girls at that age of their life. 1 to 3 year post-menarche, any cycles which are less than 21 or more than 45 days are considered irregular. 3 year post-menarche till perimenopause, cycles which are less than 21 or more than 35 days or less than 8 cycles per year are considered irregular. Similarly, 1 year post-menarche, any cycle which is more than 90 days long will be considered irregular. And primary amenorrhea is defined when a girl does not start her menarche by age 15 years or more than 3 years post-thelarche. Clinical hyperandrogenism is defined by androgenic alopecia and female pattern alopecia, acne and hirsutism. You can apply Ferryman-Galvez score to score their hirsutism. And biochemically, you can do calculated free testosterone, bioavailable testosterone. In Pakistan, we have free androgen index available. And then there's PCO morphology on ultrasound, which is more than 20 follicles per ovary. The ovarian volume is 10 ml or more, and there are no corporal luteal cyst or dominant follicles, suggesting that there's anovulation or oligo-ovulation. And in recent years, AMH is evolving as well. So either an ultrasound or an elevated AMH level would be considered one criteria. But avoid labeling PMOS when diagnostic criteria is not complete. You are aware of these different diagnostic criteria, the NIH criteria, and then the Rotterdam criteria, which is most often used in clinical practice, and then the androgen excess criteria. But remember, all these criteria require exclusion of other endocrinopathies, which can mimic the features of PMOS. So rule out hyperprolactinemia, rule out hypothyroidism, screen for non-classic CAH. If there is clinical suspicion, screen them for Cushing syndrome. If there's rapid evolution of symptoms and signs of virilization, look for an androgen secreting neoplasm. Take a drug history. Remember, certain drugs can lead to hypertrichosis or hirsutism. So, and the other thing is that not everything is PMOS. If there is predominant amenorrhea, look for rule out pregnancy. Check their LH, FSH, estradiol levels. Look for whether this is hypogonadotropic hypogonadism or hypergonadotropic hypogonadism. Dr. Naeem has already talked about functional hypothalamic amenorrhea. That is something which needs to be considered in women with anorexia nervosa or athletes. Similarly, obesity itself can be associated with hyperandrogenic anovulation. As I discussed, first year post-menarche, immaturity of hypothalamic pituitary ovarian axis. So although the name has changed, the diagnostic criteria hasn't changed. We are still adhering to the Rotterdam criteria, where in adults you will need 2 out of these 3 abnormalities, like clinical or biochemical hyperandrogenism, ovulatory dysfunction, and PCO morphology on ultrasound or elevated AMH level. Remember, AMH is now validated as an alternative to ultrasound to define PCOM in adults. And serum AMH levels generally peak between ages 20 to 25, but do not use both tests like ultrasound and AMH simultaneously to limit overdiagnosis. keep in mind that in adolescence, you have to have these two criteria strictly are required: hyperandrogenism and ovulatory dysfunction. You do not rely on ultrasound or AMH levels in adolescent patients. And if features are present but criteria aren't fully met, label them as at risk, treat symptoms, and reassess them at full reproductive maturity. Insulin resistance is the core pathophysiological defect in PMOS. Remember, insulin resistance leads to increased bioavailable and tissue insulin levels, estradiol levels, testosterone levels, and IGF-1 levels. And these actually lead to abnormal hormone production from number of tissues, from the pituitary, increased LH and reduced FSH secretion, from the ovary, increased androstenedione secretion, from the liver, reduced SHBG and IGF binding protein levels. Similarly, from the adrenal gland, increased DHEAS levels. All these hormonal abnormalities lead to a feed-forward cycle that maintains oligovulation and amenorrhea. So my next question to you is, these are two women, same age, both have PMOS. One has a BMI of 29 and one has a BMI of 22. Whom will you screen for metabolic syndrome? So can we have a show of hands? How many will screen the BMI 29 woman for metabolic syndrome alone? How many will screen 22 BMI for metabolic syndrome? How many will screen both? And how many will think there's no need to screen for metabolic syndrome? None. So excellent. So remember, so this is a meta-analysis from 22 studies and showing that insulin, and this is meta-analysis studies which were done for non-obese PMOS compared to non-obese control women. And you can see that insulin resistance, the odds ratio was 5.7, and for metabolic syndrome, it was 2.5. And thus, there's a lean PMOS trap. 20 to 30% of women with PMOS are non-obese, yet they show the same insulin resistance, adverse adipokine profile, and dyslipidemia as their obese counterparts. So never dismiss metabolic workup in your PMOS women based on BMI alone. So coming to our next case, this is a 31-year-old lady, PMOS diagnosed 8 years ago, oligomenorrhea, hirsutism. She is on combined oral contraceptive pill for 5 years, recently also complaining of anxiety, lethargy, reduced motivation. Metabolic workup 2 years ago showed a raised SGPT, imaging confirmed MESLD. The investigations revealed a BMI of 27, fasting plasma glucose is normal, HbA1c is 5.6%, triglycerides are elevated, HDL is low, LFTs are mildly, transaminases are mildly elevated, no current OGTT is done. She is currently on Dian 35, her cycles are regular on it, her hirsutism is partially improved. So can we have a show of hands? What are the next evidence-based steps for this patient's PMOS management? A, continue her contraceptive pill, no further metabolic intervention needed. How many for A? How many for B? Repeat her OGTT, add metformin, screen for OSA, address mental health, anxiety screening with validated tool. How many for B? How many for C? Switch to GLP-1 receptor analog immediately as first-line metabolic therapy. And how many for D? Refer for bariatric surgery. The BMI threshold met with PMOS metabolic risk. Okay, so we have a divided house over here. So actually, remember in PMOS, since they most often have impaired glucose tolerance, and OGTT actually becomes the best test to assess their glycemic status. Repeating an OGTT, adding metformin for her, screening her for any evidence of obstructive sleep apnea will be something, and addressing her mental health. You can see she had anxiety, lethargy, and reduced motivation. So there are cardiometabolic risk in PMOS. There is increased risk of subclinical CVD and clinical CVD. They have high prevalence of cardiovascular markers like coronary artery calcium score, carotid intima media thickness, and high sensitivity CRP levels and endothelial dysfunction. Similarly, they have high risk of MESLD, so make it a point to screen them through validated tools like PIP4 score. They can have sleep apnea, and if you screen and manage her sleep apnea, she'll be better able to reduce her weight effectively. And thus, the physical assessment, her baseline and every clinical visit, 6 to 12 monthly, should include her BMI, waist circumference, and blood pressure measurement. Lab assessment should include her lipid profile, and if there are any abnormalities, you will like to optimize her lifestyle modification or consider adding statins if the thresholds are met. And even if they are normal, you should be repeating them in 2 years' time. Similarly, an OGTT, if this normal, every 2 years should be monitored, and if additional risk factors are identified, you can screen earlier on, and if there is evidence of impaired fasting glucose or impaired glucose tolerance, repeat annually. And make it a point, evaluate them, assess them for their smoking status. We are shy asking our women patients whether they are smokers or not, and believe me, there are lots of smokers out there. So advise them on quit smoking advice as well. So lifestyle modification is the cornerstone of managing PMOS, ranging from a healthier diet. There are no specific diets, but for overweight and obese women, definitely you'll need calorie reduction, and similarly, things like healthy plate model, Mediterranean diets have shown promising results in different studies. Similarly, exercise ranging from aerobic activity to strength trainings, resistance exercises have shown their impact on a positive way. Fitness tracking devices can be helpful. Similarly, simple advice like 5-2-1-0, 5 portions of fruits and vegetables, 2 hours or less of total screen usage, 1 hour of exercise, and 0 sugary drinks. And when you are having these women adhere to their lifestyle goals and you want to then monitor them, your advice should be based upon these SMART goals. These should be specific, measurable, achievable, realistic, and time-bound. So when it comes to managing their menstrual and androgen management, remember, combined oral contraceptive will become the first-line treatment because they will manage their hirsutism and irregular cycles as well. Although no specific preparations are recommended by authorities, but prefer low dose and prefer those COCPs which have anti-androgenic progestins in there. Metformin is preferred for metabolic features for all those PMOS who are overweight and obese, although there is published data on its use in non-obese PMOS as well. Laser therapy or other mechanical means of hair removal for hirsutism, and they will definitely be needing multiple sessions. Anti-androgen should only be added as second-line therapy and should be always used with COCP if the woman is sexually active. And if there is some contraindication or the patient cannot tolerate COCPs or metformin, one can consider inositol, although keeping in mind that there isn't a robust evidence supporting their role. Metabolic screening we have discussed already. Remember, GLP-1 receptor analog can be added to their management as per obesity guidelines, and psychological and holistic care screen all women with PMOS for depression and anxiety using validated tools, address body image, eating disorders, quality of life, shared decision making. Patient agency is fundamental. Weight stigma minimization should be mandatory, and offer multidisciplinary integrated care pathways. When it comes to fertility management, letrozole becomes a first-line treatment, and pregnancy can often be successfully achieved and naturally or with assistance. So reassure your patients at diagnosis. Following letrozole, the second-line treatments can either be clomiphene plus minus metformin, gonadotropins, or laparoscopic ovarian surgery if the other things are not working. And then third line, one can move on to IVF-ICSI or in vitro maturation as well. Preconception control is very important. So optimize their weight, have their OGTT available, monitor their blood pressure, folic acid supplementation prior to conception, smoking, alcohol cessation, mental health screening and optimization before starting ovulation induction treatment. There is an increased risk of PMOS in pregnancy. There are risk of GDMs, hypertension, preeclampsia, miscarriage, preterm delivery, intrauterine growth restriction, cesarean section, and excess gestational weight gain. So antenatal management should include weight optimization, of course, OGTT preconception or first antenatal visit, and then repeating OGTT at 24 to 28 weeks of gestation, blood pressure monitoring, early lifestyle intervention. Metformin especially has some role in limiting their miscarriages and limiting the preterm birth risk. The important thing is that PMOS itself will not increase the risk of macrosomia, LGA, or instrumental delivery. Only if a woman will develop GDM, then there will be a risk. So remember that PMOS is something that is affecting a woman across their lifespan. So right through adolescence, her reproductive years, and perimenopause and beyond, we need to monitor them for metabolic disorders, keeping in mind that if a woman is presenting for the first time in perimenopause or postmenopause with new onset virilization, exclude androgen secreting tumor, they can be having ovarian hypertrichosis as well. So a lifelong reproductive health plan, including preconception risk factors, weight, mental health, and fertility goals, is recommended for all women with PMOS. So as the name has changed, what you can do today is that use PMOS, formerly PCOS, in your consultations and referrals, update patient education material, perform systematic metabolic screening at every PMOS encounter. And although we are aware of the reproductive, endocrine, and dermatological manifestations of PMOS, remember there is a host of underlying enhanced cardiometabolic risk factors that need to be screened and monitored and managed accordingly. So this is our scholarly work from Pakistan Endocrine Society and our own work published from Elsevier. So these are the take-home messages. PCOS is now PMOS, polyendocrine metabolic ovarian syndrome. The name reflects the true multi-system biology. Diagnostic criteria remains unchanged. Metabolic screening is mandatory for all, regardless of BMI. Lifestyle intervention is first line for all women, COCP for symptoms, metformin for metabolic features, and letrozole first-line therapy for fertility. Psychological health is a core component. And remember, this is lifelong. Active management continues through perimenopause and beyond. So thank you very much for your patient listening. Thank you.
Thank you, Dr. Aisha, and all the speakers for your excellent presentations. We'll now have a brief question and answer session. Since we didn't receive any question through the QR code, so we can take only 2 questions in the mic.
I have question from Dr. Urooj Rehman. So, excuse me, madam.
Dr. Urooj.
Yeah. You mentioned in your one slide, especially for the pituitary adenoma, you can say a surgeon cannot do the surgery without consent of the endocrinologist. No? So you did also talk about the octreotides. Which octreotide you mentioned is either octreotide LAR, that is the analogs of the somatostatin, and what the dose of the sandostatin LAR are simple sandostatin, and how much tumor reduced then surgeon can do the surgery.
So for octreotide is the analogs, and these are somatostatin analogs, and we use the LAR ones, which are used for this. And again, these are not the first line. So these are the drugs recommended for acromegaly, so growth hormone secreting pituitary adenomas. And the first line is the surgery. They'll do the surgery and we will send the patient for the surgery. When they do the surgery, they'll send the patient back to us, and we will see what are the IGF levels are, and how much the residual tumor is, and then we will decide the stereotactic radiotherapy, or we will start the octreotide therapy.
How much dosage of the LAR?
So octreotide is available in 20, it's 20 and 30. So we give the 20 mg 3 monthly, once monthly for 3 months, and then once monthly for 3 months. We look at the IGF levels. And if not coming down, then we can go to the higher levels, higher doses, that is the 30 mg.
Thank you, ma'am.
Thank you. Thank you.
Okay, next question. Doctor.
My quick question is for Aisha. So if there's no diagnostic criteria change, and if there's no other significant changes, just realizing the fact Do you think we can just keep the name as polycystic PCOS and call it polyendocrine cardiometabolic ovarian syndrome? It should
But
still
I
be
think that
PCOS.
everyone would agree that PCOS was actually a wrong name, so incorrect name, because that highlighted polycystic patients would come with their ultrasounds. Doctor, my cysts are no longer there. I do not have PCOS any further. So name was mandatory, that it should have been changed, and I think the new name. Is actually, I think, easier on our tongue, because we were used to PCOS. Now we can say it PMOS, but still we would agree that even this name would need to be improved over time. I don't know how come, but would need an
We can
improvement
still
over
keep
time.
the PCOS as
No,
polyendocrine,
no.
polyendocrine cardiometabolic ovarian syndrome.
Okay, another question is from Dr. Aisha, that is about the role of myo-inositol in PMOS.
So when it comes to myo-inositols, there is no reported harm in using myo-inositols. But remember, if we look at the meta-analysis, especially done on fertility and role of myo-inositols, it hasn't shown any significant outcomes. Compared to metformin or your ovulation induction therapies, those work very effectively. Those have robust scientific evidence surrounding their use. However, as I said in my presentation, there would be some women who might not be willing to take a COCP or are having side effects to COCP, or the fact that they are intolerant to metformin. You can maybe use myo-inositols over there, but not as your first-line therapies. These are expensive medications, if you are aware of the fact that these are expensive, and they are labeled as supplements. They are not drugs, so they do not go through the FDA regulatory pathway. So just keep those things in mind, and you can use if you are stuck in a situation where you cannot offer other therapies.
Okay, thank you.
Do you have to do a fasting insulin levels or HOMA IR in that?
No, there isn't a need to do fasting insulin level or HOMA IR in your patients. Remember, more than 80% of your PMOS, PCOS women are insulin resistant. If you look at their signs of insulin resistance, they mostly have their signs. They will be having acanthosis nigricans and skin tags in there. If you look at the exact method to check for insulin resistance, that is the homeostatic model assessment, hyperinsulinemic glycemic clamp technique. That is not available in your clinical practice. That is a cumbersome method only available in research settings. The surrogate markers like HOMA or other things, fasting insulin glucose ratio, will not tell you anything. Don't waste your patient's money on checking their insulin level. Monitor their metabolic parameters and go for weight reduction. That is something, and adding metformin is something that will be useful, and GLP-1s whenever needed.
Thank you for such an engaging discussion. I now request our chairpersons to share their comments and concluding remarks.
Thank you. I will just congratulate. I was really impressed by the scientific committee to choose such fantastic topics. It was loaded in the beginning, and I congratulate all the speakers. I couldn't imagine that in 20 minutes you can control those special, very widespread Cushing's and Pituitary and everything. And Aisha, our expert for the PMOS. Now we're looking forward to what can we do. What the two messages are there. Number one, any patient with pituitary mass comes to you, they don't always go to the endocrine, they don't go always to the neurosurgeon. Don't refer to the neurosurgeon. Any patient with PMOS, that is the most important part for the name change. Don't send them to the gynecologist, send them to a metabolic doctor. And who is the metabolic doctor? Endocrine. That's my comment for today. Thank you.
I would like to congratulate all the four speakers on the excellent talk, really, on the topics assigned to them. One of the audience, one of the person from the audience had asked this question about why should this surgeon be asked by the endocrinologist? Because the reason for this is that Urooj was trying to highlight was that there are many cases in all institutions where the surgeons have operated on patients who had prolactinomas and they were not screened for it. And that is one of the main reasons why the patient should be referred to the surgeons by the endocrinologist. Recently, I had a case where a patient was sent to me by the neurosurgeon because the patient had Cushing's syndrome, and they did an MRI, and there was a micro adenoma in the pituitary gland, and he said, "Okay, I'm going to, if you say okay, I'm going to operate on it." But when I saw the patient, this patient was like an ectopic ACTH syndrome, and I worked him up, and it was an ectopic ACTH syndrome, and he had a net tumor in around the duodenum. So, I mean, I think this gives us a message that these cases should be seen first by the endocrinologist, and even if the surgeons see them first, they should refer back to the endocrinologist, get their agreement, and then proceed with the surgery. So that's what my comments for this related to the Urooj talk. But the rest of the talks were very relevant and very recent and very up to date. And I congratulate all the speakers on this.
Thank you very much. I think so. All the 4 speakers has done a really wonderful job. The thing which I'll always appreciate is on time, which is really very important in our meetings. Dr. Urooj, Naeem, and Dr. Uneeba, I'm happy to see the young endocrinologists are now leading their meetings. Now they are not only leading the institutions, but now they are leading our meetings. The society which has been established by our seniors 20-25 years ago, now this is giving the fruit, and the young generation of endocrinologists are coming. And we are happy to see that Dr. Ali has just mentioned in his speech that in the small places, the endocrinologists are there. I think so. This is actually the fruit which will go to the patient. And I agree with Dr. Jabbar that absolutely when someone is coming, is always a teamwork. When you see somebody which is coming to the general physicians, general practitioners, family physicians, he should be sent for a proper diagnosis or proper management to the endocrinologist before sending them for the expensive investigations. Thank you very much.
Thank you. And thank you all the chairpersons, speakers, and participants for such an excellent scientific session. Please remain seated as we transition to the next session. For that, I would like to invite Dr. Kifayat Ali, who will be moderating the next session.